Airway and ventilation, whether you're looking at the March approach, CABC approach, XABCDE approach, as in the 9th edition of PHTLS. Generally, in the initial phase, we'll have managed the airway, but that can change. The patient might be able to manage their own airway initially and deteriorate and require the medic to intervene, whether it be a standard airway, OPA, NPA, supraglottic, King, iGel, or there may be a need, in the case of burns, anaphylaxis, to do a surgical airway. We might need to ventilate the patient after. So consider gastric insufflation, consider the possibility for aspiration and the need to provide definitive airways. Consider that the gold standard over a prolonged period is automatic ventilation. If you've got an automatic ventilator, great, but have you got access to power? How long is it going to last? How do you manage the patient if there's an interruption to power, as there is here in Afghanistan every 20 minutes? Maybe you need to bag the patient for prolonged periods and train other non-medical team members so they can take over and appropriately, not too zealously, particularly if we've got trauma to the lungs, but they can bag the patient at the rate you train them so that you can do other more important advanced tasks such as monitoring vital signs, drug administration and advanced interventions. Assessment of the patient. We've got our initial assessment, then the ongoing assessment as with any environment. So your ABCs, top to toe assessment, checking for and managing further wounds. You could even look at ultrasonography, taking portable ultrasound to the field. Years ago it might have cost you $30,000. These days you can pick up a half-decent ultrasound for $500 from China, put it in a Pelly case, and you've got a great portable solution to do a fast scan and look for a free fluid in the abdomen to identify bleeding potentially. You can use it to identify intracranial pressure via measuring the diameter of the optic nerve sheath. That will be an indicator if we need to intervene pharmacologically for intracranial pressure to prevent herniation. You can identify tension pneumothoraces via the movement or lack of the pleura, identify cardiac tamponade, fluid in the pericardium. You can even use it to guide airway placement, confirm placement, or to cannulate in an extremity. Ongoing assessments on the patient, check all your interventions constantly, check that the tourniquets are still effective, check that your Foley catheter is functional, it's not blocked, it hasn't been dislodged, IV access is viable bilaterally. Remove and replace all wet clothing so as to prevent any conduction or evaporation, convection, and try and stave off that all-important hypothermia. Then conduct our sampler history, as you would normally: signs, symptoms, allergies, medications, past medical history, last oral intake, ins and outs, record it, any risk assessment or risk factors which could compound or complicate the current patient situation, and then create a plan to mitigate them. A lot going on here. Now we're on P, personal and team admin. So you're operating under the same extreme conditions in an austere environment. So to be able to stay healthy yourself as a medic, make effective decisions, you need to be fit enough to evacuate a patient, communicate. And to do all that, you've got to get into a work-rest routine. Maybe you're alone, maybe there's another medic with you, maybe there's a first responder, or you might have to train somebody in your group to help. But you need to get into a work-rest routine if it's going to be a prolonged situation for a couple of days. So consider hydration, nutrition, hygiene, resting out of the elements, take your PPE off and air off, vent off if you can, get some adequate sleep. Consider employing somebody else that you trust to monitor vital signs, parameters, and wake you up or guide you if there's any changes. Analgesia, apart from the humane aspect, it's also protective both emotionally and physically. As soon as practicable, after getting out of the care under fire stage and managing the ABCs, think about a patient care plan, think about controlling pain as quickly as possible. Start off basics, emotional support, positioning, splinting, and then you can even start off building up your pain meds stack paracetamol, ibuprofen, codeine to save your opioids, or revert to ketamine drips as opposed to continual boluses. You've got to consider how your supplies are going to last the full duration of the prolonged care until you're able to access better resources or evacuate the patient. Position, packaging and portage. Doesn't really matter lying the patient in the supine position on a backboard during a transport from the street to the hospital over 10 minutes. Still not the gold standard, not particularly comfortable, but it becomes more of an issue in a prolonged field care environment. It's not comfortable, it's not an adequate anatomic position, it could cause pressure sores, so we need to try and make the patient as comfortable as possible, whether it be in a vacuum mattress or padding the anatomical spaces under the knees, under the spine, make them as comfortable as possible. Maybe rotating the position to take the pressure off, because we don't want any sores becoming infected, particularly in that environment. And if the patient doesn't have a definitive airway because of resources or skill set and is unconscious and has potentially had recent ingestion of food or liquids, there's a good likelihood that they'll vomit or they'll aspirate. So you might want to consider putting the patient into the side lateral position and monitoring from there. Portage then. How are you going to carry your patient during the ruck phase to the truck, or from the truck to the house, or from the house to the waiting helicopter 400 metres away, 4 kilometres away, crossing rivers, trekking through the jungle? We need to make the patient comfortable, consider C-spine considerations, consider the principles, make sure that we're not pulling on any leads, cables, oxygen tubing, IV lines, get everything tucked away, prevent conduction, convection, radiation, prevent the patient from overheating or becoming hypothermic. So we need to consider what is the most appropriate way of protecting the patient and the most efficient way of carrying the patient so as not to put the team at risk, and practice it. Environmental hazards, we've already talked about. Protecting the patient from extremes of heat and cold, insulate from the ground, insulate from the sun. That applies to the first responders, the rescues teammates as well. You could consider the employment of bothy bags, foil blankets, tarps, tents, foam mattresses, camping mats, even chopping down branches and putting branches and foliage on the ground to insulate from the cold. Very easy to become tunnel visioned on the patient, watching the beeps on the monitor, recording the vital signs, titrating medicines to effect. But it's such a dynamic environment, things can change, whether it be enemy action, the weather. Water levels can rise if you're in a riverbed. You can have deadfall in the jungle, rocks falling down, avalanches. So you need to maintain your situation awareness. Ideally, nominate somebody specifically responsible for the safety and security in the area. It will change, and we need to react to it. Antibiotics. Prophylaxis should be considered as early as possible for things like penetrating wounds, signs of sepsis or meningitis, using a good broad-spectrum antibiotic in line with your scope of practice, medical direction, whatever's available. Rocephin is a good one that's available in most countries overseas. Ertapenem is what's recommended by the Committee on Tactical Combat Casualty Care these days. I haven't found it in Afghanistan. I couldn't find it in Kurdistan. We carried ceftriaxone, but if you can take it with you, great. If you can't, you need to try and source medications in country and identify if they're from a trusted source. Ensure they're not counterfeit. Signs and symptoms. We need to have some sort of monitoring capability. Constantly monitoring the vital signs is essential so we can identify trends and determine if the patient is improving, staying the same, or deteriorating, and respond to it immediately. Vital signs will guide your emergency management, prolonged field care needs. In an ideal world, we're going to be monitoring multiple parameters simultaneously, but in our environment there's several challenges. What equipment do we take? Can we afford it? Is it light enough to carry, or is it too heavy, too bulky? How do we interpret the data? Who can we send it to interpret the data? How do we contact them? How do we power the equipment to be able to take the vital signs and send the information? So working on the minimum better best, looking at the pulse rate, minimum, we can use a pulse oximeter. Ideally we want a vital signs monitor, something like a LifePak 15 would be absolutely fantastic, but not practical if you're living out of a rucksack. So maybe a pulse ox, something small enough to give you saturation readings and pulse rate. CO2 detector, ideal if you're going to be an essential, if you're going to be doing things like sedation, surgical airways, definitive airways. Blood glucose, glucometer, small enough, light enough. Respirations, going to be observing the patient, auscultating all of the fields. Blood pressure cuff, small and light enough to carry one. Urinalysis, you can take the little urinalysis reagent strips, take a handful in a sealed plastic bag. Urine output, Foley catheter and a bag. Ideally we want to be seeing a urine output of 30 millilitres an hour or over, and we can monitor that and test the urine from the bag. Blood chemistry, ideally you want an iStat machine, but at $5,000 it's unlikely we're going to have one on every single expedition, but it's a consideration perhaps if you're operating out of a base camp or an oil rig, etc. Cardiac rhythm, be nice to have a LifePak 15, not very realistic, but these days for a couple of $100 you can get cables that plug into your iPhone or a smartphone and you can monitor cardiac rhythm. Some of them even give you a 12-lead ECG capability, and some of them you can connect via a satellite Wi-Fi hub and send the data straight back to your reach-back telemedicine director or cardiologist and get immediate feedback, albeit asynchronous. They can send you an email back. But yeah, the technology is getting smaller, lighter and cheaper, and there's really no excuse for not having the capability in remote areas these days. Neurological status, ABD, GCS scale. Intracranial pressure, we can do a mini neurological survey, vital signs, use the ultrasound to measure the diameter of the optical nerve sheath. Ventilation and possible tension pneumothorax, we can auscultate, we can inspect, palpate. We can also use the ultrasound to look for the movement of the pleura. Cardiac enzymes, if we suspect somebody's having a myocardial infarction, aside from the 12-lead ECG, you've got a rapid point of care test, around about $10 depending on where you get them from. A tiny piece of kit, and it gives you a good indicator of the patient condition to try and make a good patient assessment. Temperature, oral thermometer is your minimum. Best is obviously a rectal thermometer to get a good central core temperature. Might not be practical in a remote environment. So whilst the best practice should always be going for the best standard, it might not be practical on an expedition. For example, a small solar charger, small power monkey might be enough to power a smartphone and therefore your cardiac monitor, your 12-lead, but it's certainly not going to be enough to recharge the battery on a LifePak 15. You'd probably need to have a generator back at the base camp in order to charge the batteries of a LifePak 15. So look at what's practical, look at what's sustainable. Emotional aspects, group dynamics and leadership. Unless you're doing this day in, day out, this is your bread and butter. In major incidents or remote environments, panic can be infectious, contributes to increased risk, unnecessary use of resources, poor decision making. So you really need calm, level-headed leadership and effective communication constantly to maintain discipline, maintain a cohesive unit, share information. So mutual respect, information sharing contribute to a sound environment where you can make sound decisions in the best interest of the team, bystanders and the patients. Apologies for the noise, guys. The Black Hawk and a Chinook are going to fly over.